In this video, I cover the clinical presentations, causes, and successful treatment process when a client presents with tennis elbow. I cover the following in the video: clinical signs and symptoms of a tennis elbow problem, two causes of tennis elbow that most providers rarely account for, a non-surgical treatment process designed to produce long-lasting pain relief, and the importance of educating the client on proper load management to allow for optimal results. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a non-surgical expert in chronic pain treatment. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach massage therapists a new treatment system that eliminates the frustration of inconsistent results and produces long lasting pain relief for their clients, all while working 50% less. All right, let's get right into it. Clinical case management for tennis elbow, causes, treatment, and load management. I'm not a big fan of like what I call like junk box diagnosis, where they just say, hey, it hurts out here in the lateral part of the elbow. Must be tennis elbow. It doesn't really tell us anything. We always need a tissue specific diagnosis because if you don't know what the problem is, you sure as hell can't fix it. So, what I'm seeing, this is going on. Oh, I'm getting old. Like, this is 17 years in practice. I've seen a lot of these presentations, messed them up a lot, had good success, never really knew what was going on. But a lot of what I'm seeing in the pain presentation and the overall dysfunction is an underlying nerve entrapment, somewhere along the course of where it goes. I used to think nerve entrapments and then just regular like muscle adhesion and the ligaments and the fascia were equally as important. You need to treat them, but they're all important. But you got to treat the nerve entrapment in the nervous system first. I think the neuromuscular people have it backwards. I think it's like a wiring with the brain and things aren't moving correctly, not firing, inhibited, upper cross, lower cross syndrome. All that stuff doesn't make sense to me. Something's getting stuck outside and it's causing those issues. And when the nerve gets stuck, it causes a lot of problems. So clinical presentations, a lot of times with a nerve entrapment, usually starts with like some numbness, some aching, some burning, and some tension. Over time, though, when the nerve entrapment does occur, it causes all the muscles around the area to engage in what's called a protective tension. That protective tension is trying to unload that nerve entrapment and take the pressure off of there because the body's hierarchy is it wants to protect the nervous system. Because if the nervous system doesn't work correctly, nothing else works correctly. So a lot of times these present as they go. So nerves are built with about 15 percent of extra slack to make their way through where they need to go. They originate up in the neck and then work their way all the way down through there. And the biggest and like farthest path nerve in the upper extremity is actually the radial nerve. It goes a long way from where it goes. So over time, usually what happens is with repetitive overuse, oh, you can see it in some injuries and accidents, but I tend to work on people that have had like no direct injury or trauma where things just build up. And with just repetitive overuse, sitting too much, sedentary lifestyles, muscles get overstretched, don't get enough blood flow, don't get enough oxygen, develop that stuff. I call it adhesion or scar tissue. And then eventually it does get stuck to the nerve. And a lot of times when a client is feeling like pain somewhere distal down the arm in the nerve distribution, a lot of times you need to check all the way up, especially if there's no like direct trauma to that area. It's going to really help you understand um, that it's coming from somewhere else. And a lot of times down lower is more the effect and not the true cause. So, treatment process for this is I'm just going to check the whole radial nerve, basically from the neck all the way down into the forearm. The first area where I do check is usually going to be in between the supinator and the extensor groups in there, and the radial nerve gets stuck right there. Because usually what happens is it's caught higher up, so it's pulling more there. So most of the tension is actually occurring there, which in turn causes more of that adhesion and scar tissue to lay down, more of that inflammation. Why the client actually comes in with that lateral elbow pain complaint. And a lot of people just kind of want to start there and only treat there and don't think of the rest of the contributing factors in there as well. Then the next place it does get caught is between the brachialis and the tricep as it goes in there and starts to move and work its way through. This area is usually really tender when you find it. And a lot of times when people are trying to address that area, they usually end up being too much on the brachialis or too far lateral on the triceps, and they're not actually on the nerve. The nerve is right there. You can go in there and feel it's like a little stringy type of feel, and you'll know you're on it where it's caught. It'll kind of light that patient up, and they'll be like, "Ooh, I feel that." Next spot we're going to look is going to be into the subscap and the neurovascular bundle. They form what's called the brachial plexus and things like that, and they're contributing into the radial nerve. The radial nerve is higher up in there, up in this distribution and through here, and I can usually catch it like way up in the tunnel in there as well. A lot of people, when they go and treat in there, they're actually too aggressive and they think it's just a subscap and they have to beat the hell out of it. Or a lot of times these get missed as like a pec minor tightness, and they think, oh, the pec minor is the issue, or the pecs are tight, we need to stretch them or release them. But that's where that protective tension comes in, because this area is trying to unload in through there as well. And then lastly, I go up and check in the neck where the root source of the problem is. Radial nerve, like I said, is the biggest nerve of the upper extremity, and all the nerve roots really form into there and innervate into there as well. So I'm checking the nerve roots in between the scalenes, usually between the anterior and middle scalenes, if they're having more of a forearm elbow type of problem as they go through. We cover a lot of these trainings and these treatments and all that in our advanced training stuff. I don't want to put it all in this video, but if you're watching it anywhere else on the YouTube channel or anything like that, there's so many instructional videos on every single one of these areas and how to go in there and actually find them and fix them. Next thing I want to talk about is this idea of what's called a tendinosis. So when most people think of pain in the tendon or the elbow, they think it's this stuff called tendonitis, but it's actually a tendinosis. So what happens is when there's the nerve entrapment, there's the adhesion built up in the muscles around there. The force has to go somewhere and it ends up going to the tendon, and it actually creates a big problem called a tendinosis. So what I want to link up in the video this week is just a 2-minute explanation of me going a little more deeper using some whiteboards and talking a little bit, kind of nerding out a little bit about what tendinoses are, what they do, and how they form. So I'll link that up right now.
Hello everyone, getting our educational video out. Today I want to talk about the idea and the diagnosis of tendinitis and how it's one of the most common diagnoses out there for injuries in the body, but it's actually incomplete and is actually very uncommon compared to something worse. So what we pulled up here was the Wikipedia page on tendinitis. Basically, tendinitis means inflammation of a tendon. It is a type of tendinopathy often confused with the more common tendinosis, which has similar symptoms but requires a different treatment. That's the key, the different type of treatment. That's very basic, but it means a big deal of a lot of things. So a lot of people are walking around when they have pain in their elbow, wrist, forearm, shoulder, anywhere. They get this diagnosis of what's called tendinitis. Tendinitis just means that it's inflamed. But if it's something that's chronic and been going on for a long time, a lot of those situations are actually isn't inflammation in there. There's actually something a lot worse, an actual degenerative component of the tendon. So when you look at a tendon, normal healthy one basically looks like this. It looks like spaghetti in a box before it's cooked. It's really strong and it would be really hard to snap. That's a normal healthy tendon. But over the years with wear and tear, bad mechanics, injuries, inflammation, everything on that, the tendon really gets beat up because the muscles around there aren't working correctly, and it develops what's called a tendinosis. So a tendinosis is, if we look under a microscope, a tendinosis looks like cooked spaghetti. The problem with that is that area of the tendon is very weak. It doesn't get good blood flow, it doesn't get good oxygen, and causes the pain and inflamed type of feeling that you're feeling. What's going on in the current medical model is everyone is addressing tendinosis thinking that it's a tendinitis, and they want to get the inflammation down, so they inject it with cortisone. When you do that, that actually speeds up this tendinosis process, makes this tendon even more degenerated, and they're actually showing more and more if you're likely to get a tear or some type of problem, it's because you had a tendinosis first and the cortisone makes that worse. So there's a big difference in the proper type of diagnosis. So if you're walking around with a tendinitis type of diagnosis, you've done multiple injections, and you're still not any better, it might be time to figure out that you actually have something way worse, a tendinosis, and those are more likely to tear.
So you can see these tendinoses are a big deal, and they often get missed by a majority of providers. And 97% of tears in tendons were originally a tendinosis as well. When we are going to treat the tendon itself, I'm going to use an instrument to go in there and basically break down that bad tendon. As we do that, you can't really get it with your hands. Some people will use like a shockwave treatment. It can help, But they're expensive to buy and they don't always do the best job. So that's why I like to use the instrument in there to go in there and break that down. But I only do that after I follow a full process. Then we do some eccentric exercises to regenerate the tendon. So basically, we're going to treat all the adhesion, get the bad tendon out of there, then build the tendon back up. That's how you're going to get it functioning better. So a big thing with these problems are load management and, following the process and not jumping around. First is you got to explain to the client or the patient the idea of load versus capacity. And basically what I do is I draw a teeter-totter, and on one side I draw a load, on the other side I draw a capacity. And I say load is what you do, capacity is what you can take. The reason you're injured is because your load exceeded your capacity. So what I'm going to be doing during the treatment process is I'm going to be cleaning up all your tissue, getting it functioning, moving better and healthier so you can handle more load and handle more capacity. But if you're doing more load in between, it's not going to get any better. I will put someone in an elbow brace, a tennis elbow brace during the treatment process if they need to work or they have like a manual labor job or something like that. But I'm not doing it so they can like go back to exercise and do more. It's really just to help ease the load. Then we must restore the range of motion first by finding and fixing the adhesion, treating the nerve entrapments. I teach all that in all my trainings, all the videos. You can find that everywhere. That's going to get the tissue healthy first. Then we're going to break down the bad tissue in the tendon using the instrument. Then we're going to do the eccentric loading of the tendon to regenerate better tissue. Once we get it in a good place, we're going to go with some ongoing maintenance treatment. Once I get it all cleaned up, it usually takes me anywhere from 6 to 10 treatments to get it in a good place. And then we usually see them every 4 to 6 weeks to keep things clean, keep this tendinosis from coming back, keeping things functioning. It's kind of like getting the cavity drilled out first and then coming back to the dentist later on to get a cleaning before the cavity becomes bad. All over again. Don't ever feel bad about maintenance treatment. People need it. It's important. And don't be one of those people, I'm going to treat you and fix you and never have you come back again. Not possible. But you're going to save them from surgery, save them from bigger problems, and coming in once every 4 to 6 weeks ain't that bad for the client. That's all I got in the video. Appreciate you watching. Share any insights you might have gotten in the comment sections below or any questions you have. I try my best to answer all of them, share resources that I have, and just share knowledge. If you like the video and you know other providers that it might help, do me a solid and share the video with them as well. Always looking for people wanting to do good work, help people, and just get better results for clients so they can stay the hell away from pain pills, injections, and surgeries, which only make things worse. And lastly, if you like what I'm teaching, what I'm training, go download our free training modules where we really go into the whole system of finding and fixing problems, becoming a true problem solver. Links to that are wherever you're consuming this video. I appreciate you watching, and I'll catch you on the next one. Bye.